As I've thought about single payer over the past 20 years, one thing I never hear addressed, and you touched on it in a negative way about the high cost of administration. That administration cost is really people. If we went to single payer, think of the thousands of people employed at insurance companies, health benefit companies, administration companies that would be without jobs if we had single payer. How do we address that?
Yeah, it's important. It's actually addressed a lot by me when I speak about single payer, because someone in the audience always asks this question, because it's a huge
You're
concern.
ready for it.
Yeah, well, no, I mean, it's a common question, and it's a very valid very valid question and concern. And there are many people in the United States and in Minnesota employed in the insurance industry, and they would frankly become unnecessary. Not all of them. I mean, there are some administrative functions necessary in a single payer, but far less than what we have now. So I have several thoughts about that. I mean, one thing to remember is when people in the United States lose their job, one of their first concerns is that they lose their health insurance. I mean, a lot of people hold on to jobs here just for their health insurance. So one good thing is that folks would not lose their health insurance when they're in that situation. But a lot of the people working for insurance companies are quite skilled. Insurance companies employ doctors, they employ nurses. So many of these people are folks with skills that could be transferred to other jobs. And then there are, depending on the bill that you look at, in our Minnesota single payer bill, because of the savings that come with single payer, there is money set aside for both unemployment benefits and for job retraining for those displaced workers. But yeah, and I guess I would just say the healthcare system shouldn't be a jobs program for if there's really unnecessary work, we shouldn't be doing it.
But you could do it through attrition.
Right, and also through helping folks get replaced, yeah.
What other states are looking at? I know Vermont has been looking at this very carefully.
So Manny mentioned Vermont, which is the closest to single payer that we are currently. Massachusetts has been mentioned, which is not close to single payer. People get confused and they say, oh, are you talking about what Massachusetts did? And what Massachusetts did was implement an individual mandate for folks to buy insurance. And that's what we're doing nationally. So that's certainly not single payer and not what we're promoting. So really Vermont's the only, there are many states who have single payer bills and who are working on single payer, but Vermont's probably the closest, yeah.
Any panelists have questions for Ann about single payer? Okay. We were supposed to start questions at 8 o'clock at 7:43, so we're a little bit earlier, which is very good. We have a very diligent panel on staying on time. And I thought there'd be more questions back and forth between the panelists. But I want, before I'm going to ask a question of the panel, and while I'm doing that, there are 4x6 cards at your table and pens. I guess they're more bigger than 4x6, or maybe they're not. So please write your questions on that. If you want to identify a specific panelist to answer that question, put that panelist's name down. If it's just a toss-up question for the panel, it can be that as well. And while they're collecting those, I'd like to go back to Paul. One of the things, again, that I saw in your TED presentation was very intriguing, and that has to do with payment reform. It's something we really haven't talked about a lot this evening, but there are some really interesting models of payment reform that are being tested right now for physicians' compensation, other than just being paid by procedure. Would you like to share some of the research that has gone on with IBM on different payment methodologies that may be coming on stream and are already? I know some of them, I think WellPoint already has one, and they're one of your biggest insurers.
There's quite a few that are rolling out, and I think what's really happening is that we're beginning to have multiple dials. And whether it's single payer or, the Lord Douglas model out of Canada, or, the Bismarck model, which combines government, whichever model you use, how you drive payment for what you buy, it has to be mandated, and or has to be sorted out. And if you only have one dial, it's really difficult to make change. But if you have multiple dials and you can adjust those dials, and that's what I've seen in many places. So, for example, if you have a dial that pays a certain amount for capitation and for managing a population, and a dial that pays those kinds of services that you want fee-for-service at the primary care level. If you want moles removed at primary care, you know, some sort of a fee-for-service incentive for those procedures to be done. And then you have another dial for the level of service. So in one environment that I went to, if you answered your emails in 20 minutes, you got 5 times as much money than if you answered it in 24 hours. And if you saw a patient in 2 hours, you got more money than if you saw them the next day, right? I mean, so if service is what you're after, then you put a dial in place that pays the providers to deliver that service, and you get the service. If it's outcomes you're wanting, if it's quality that you're wanting, then you put a dial in place that begins to pay against quality, and you stop paying already only fee for service. I mean, if all you do is pay fee for service, you're going to develop a milking machine, right? Because we know what happens, because people are getting pretty good at delivering services, and we create a hamster wheel kind of effect. So, I mean, it isn't rocket science. I mean, you don't have to get the dials perfect. Everybody thinks you've got to sort out the exact perfect payment. You don't. Put the dials in place, and if you end up paying too much for quality, then you back that down and you pay a little bit more in service, and you can adjust them, right? So that's how I would look at it. I mean, again, it isn't that hard.
All right. Thank you. I was going to mention something, and I'm sure you've seen this before. Thank you. There's a report, it actually came out last year in dollars and cents. It says economy in numbers. And it says funding a national single-payer system. And it's very quite interesting because it also has it all graphed out as to where the savings will come from. So I would invite you to go online to dollars and cents if you're interested in learning more about single-payer. And it builds a very strong case in favor of it. Okay. All right, thank you. Paul, here's a question for you. In all of the national discussions regarding lower health care spending, no journalist, practitioner, etc., I gotta read this, primary care and more robust primary care model as part of the solution. Why not?
I'm not quite sure what the question is. Are you saying that in none of the...
Please.
Yes.
I'm not talking about us in here. I'm talking about all the fiscal cliff discussion, all the upcoming discussion about Medicaid, Medicare, defense spending, so on and so forth. Every day I follow national politics, and I don't ever hear politicians or journalists covering this saying, oh, well, I know the solution to lower costs. Well, we'll just, we need a more robust primary care system. The wrong people, we don't seem to be getting this message out, because I listen to talk radio, I read Time Magazine, I read the New Yorker, I read the Minneapolis Star Tribune, and on and on and on and on. And I keep waiting. When am I going to hear primary care as a solution to lower Medicaid or Medicare costs? I never hear it. So we don't seem to be getting our message out, because I'm not hearing it echoed.
So I think I wouldn't be quite as discouraged as that. I had the privilege of attending the National Governors Association not too long ago, and I had a meeting with the Lieutenant Governors Association, and last week I was privileged to be invited to a meeting of 17 members of the House and Senate, both sides of the aisle. And I can tell you that there's a lot of these folks who get this, who are really patient-centered medical home groupies at this stage. Senator Kay Hagan was the co-author of an article on this with me in Health Affairs not too long ago. So, I mean, I think that our message is getting across, and there are actually well over 100 books that have come out in the last couple of years, and there's all kinds of movies, Escape Fire and Waiting Room, and many others that I've seen that have been around this national dialogue. So, I mean, I think we've been more effective than we think we have at getting the message out. I mean, you're right. I don't hear it talked about too much, but a little bit, you know, on the talking heads on the cable TV and, you know, and the, you know, Fox News kinds of channels. A bit on NPR, I hear a bit from time to time. In fact, there was just an article yesterday on NPR talking about this. So, I mean, I'm not totally discouraged. But I think you're right. We probably need to do a better job. And that's why we formed a national coalition, the Patient-Centered Primary Care Collaborative, to try to drive this message. You know, we need to drive it harder.
Manny, this one's for you. This is the second time hearing your talk. I am still quite confused.
I'm doing my job.
Despite Navigator, how can my indigent, undereducated patients choose a sustainable plan?
Okay. So forget about the labels. There's going to be assistance for folks in a number of different mediums, whether they want to access information online or through a 800 number or through currently trusted advisors in their community. Because my colleagues at the Exchange are talking to folks in the faith community, in the care delivery community, in the social service community, about how do you help people make the transition from being uninsured to being the holder of an insurance product. That's the process and the concept. It will take a remarkable amount of work to get to that point. Some of which will include mass media. So, for example, my former colleagues on the communications side are thinking in terms of TV advertising and radio spots and bus billboards and just fundamental sort of outreach and education. But a lot of it is going to have to occur with one-on-one conversations with trusted advisors in a number of different walks of life. Navigators are a form of trusted advisor. Trusted advisors can include doctors, can include chambers of commerce, can include labor unions, can include the faith community, can include the county social service worker, for example, if they're getting service food stamps and other forms of public programs. I would say it's all of the above. That's the intent. If we pick a single form of outreach and education, we will succeed with the people who access information in that form of outreach and education. It's got to be meeting people where they're at and how they process information.
Thank you.